Good afternoon, and warm greetings to all our colleagues, friends, and distinguished guests from Lebanon, the whole Arab region, and Europe. My name is Farid Zaytoun, and on behalf of the Lebanese Society of Allergy and Immunology, the Pan-Arab Society of Allergy, Asthma, and Immunology, Area International, and the Area Group Lebanon, it is my distinct pleasure and honor to introduce and welcome you to this exciting webinar event, namely the official launching of Mask Air Lebanon. In this day and age, mobile health, which is the use of information and communication technology in healthcare, has become increasingly popular, with the potential to profoundly affect healthcare outcomes, and particularly so in chronic diseases. Allergic rhinitis is the most common chronic disease worldwide, and along with asthma, they represent a great example of a chronic comorbid respiratory condition. The area allergic rhinitis and its impact on asthma guidelines that were founded and introduced more than 20 years ago by the esteemed Professor Jean Bousquet are considered the golden standard for managing this condition. Over the years, area has considerably evolved from the first multimorbidity guideline and in respiratory diseases to the development of real-life integrated care pathways, and now into digital transformation of health and care through the creation of MASK Mobile, which stands for Mobile Airways Sentinel Network. Out of this MASK initiative came Mask Air, an internationally renowned mobile health application that is freely downloadable on iOS and Android cell phone systems. It is specifically designed for patients with allergic rhinitis and asthma, and significantly focuses on the management of patients with chronic airway disease. The app is being used by thousands of patients in more than 33 countries, has been translated into 20 languages, and is endorsed by medical, academic, and legislative organizations in Europe, America, and Asia. For more than 2 years now, the Lebanese Society of Allergy and Immunology and our national area Lebanon group, which is co-chaired by Professors Carla Irani and Philip Rawadi, have been working very closely with Area International. The hard work of all parties involved, especially the diligent effort and vision of our local project leader, Professor Rawadi, has finally come to fruition with the creation and launching today of the Mask Air mobile application here in Lebanon, after the translation and redesign of the international Mask Air app to an Arabic version to serve specifically our Arab region with the endorsement of all stakeholders. The app has already been registered on App Store and Google Play in Lebanon. It can immediately be accessed that way or by logging into mask-air.com/AR. It is the vision and intention of both the Lebanese Society of Allergy and Immunology and the Pan-Arab Society of Allergy, Asthma, and Immunology, PASI, that Lebanon serves as a kickoff country and becomes a prelude to implement Mask Air across all Arabia. Finally, LSAI and PASI are very appreciative of their partnership with Hikma Pharmaceuticals, both on a local and global level, which was very receptive from the very beginning to this alliance for chronic respiratory disease, and has been a most dedicated and supportive partner in this project. We thank them. We promise you today an extremely interesting program, and we are excited to have Professor Bousquet on board. But we will start first with a 2-minute video from Hikma. Thank you. Okay, we will start our program now. It is my distinct pleasure to introduce my good friend, Professor Carla Irani, who is the co-chair of the Area Study Group Lebanon. She is currently the president of the Lebanese Society of Allergy and Immunology, a National Society president and a member of PASI. She is a lead researcher in the field of epidemiology and immunotherapy in patients with allergic rhinitis and severe asthma. She will give us a glimpse on e-health in Arabia. Dr. Irani.
Thank you, Dr. Zaytoun. Thank you, everyone. I would like to start by thanking Professor Bousquet for this great opportunity to make Lebanon a part of this exciting application. I like to thank SciencePRO for their help, Hikma, of course, Professor Rawadi and Professor Zaytoun. So today I will give you a short presentation about the acceptance of digital health in the Arab world. I started my presentation with this line, actually, air application, your health is in your hand. This is really great, a great application and a great opportunity. Let's talk a little bit about asthma and allergic rhinitis in the Middle East. What do we have as far as epidemiology? We know that the prevalence of asthma among the adult general population in the Middle East, and this was in 5 Middle Eastern countries, varies from 4.4% to 7.6%, which as from this study, it is lower than the prevalence reported in Europe and North America. Allergies in the Middle East survey, nasal allergy in the Middle Eastern population showed that whenever we have a physician diagnosed asthma, 68% reported having asthma symptoms or asthma exacerbation whenever they have allergic rhinitis, the prevalence being 10% of respondents who had a physician diagnosis of allergic rhinitis or equivalent, which is, as you see, very low, and that is usually due to the fact that most people suffering from allergic rhinitis, they don't reach a physician. But if you see the case in intermittent allergies, you see that the numbers go much higher, up to 79% in KSA and 68% in Egypt. In Lebanon, the publications showed a prevalence of 44%, which is very similar to Europe and other modern countries. What do we have as far as sensitization in the Middle East? Well, if we take this study, we have, of course, outdoor and indoor allergens, mainly dust mites. In KSA, UAE, we have not only the dermatophagoides steronicinus and farine, but we have also the blomia that is common because of the warm climate. This study was taken from in the Jordanian allergic rhinitis patients, where you see that the sensitization is higher to trees, mainly olive trees, grass, but also to mites. And this is a publication that we did back in 2013, showing also a high concentration of pollen, especially during the spring season. Mainly we have cypress trees, parietaria, grass, and olive trees. Electronic technology actually is part of various aspects of our modern society, and many people now use the internet for shopping, social networking, banking, and also for seeking health information. How many times patients come to your office thinking that or telling you that we looked this on Google and that's what we found. And using applications or web portals is very important, is an important tool also for these patients in health, whether to increase their physical activity, to seek for diet control, and also for smoking cessation. So really, acceptance of digital health is very essential for its success. And studies on users' acceptance in the Middle East region are scarce, but I will present to you mainly two interesting recent studies about the acceptance of digital health in the Middle East. The first study actually was launched in 2015 in the UAE, where they used electronic patient portal to see in the daily practice about the daily practice of various developed countries about the health in the Arab world, knowing that only 12% of healthcare organizations offered this service in the Arab world. So this publication was done in 2020 in the British Medical Journal, Medical Informatics and Decision Making. And if you see mainly in this figure, the red is for physicians, the blue in patient. You see a little bit discrepancy whenever you are looking about the behavior intention of using the application. It's higher among physicians or providers. The perceived usefulness is higher among patients, and the social influence is higher among patients, whereas the ease to use is more common among physicians than among patients. So really, these four factors that were published in this study were very important to really assess objectively whether the patients and the physicians are willing to use any in this electronic patient portal, but it can be any health. And mainly the questions, the difference between behavior intentional to use and the perceived ease to use were very important. There were specific questions asking both physicians and provider and patients about the intention to use this to see medical record, to schedule an appointment, to refill mention, and this is important, to see if they have to give the daily weight, daily blood glucose, physical exercise activity, but most importantly, also to receive education to help self-manage their disease. Also, the perceived ease to use, whether it is very easy to understand what's written in this application, whether it's easy to post information on this application, and also to communicate with the physician via this electronic patient portal, and also to look at any information posted by physician. The perceived usefulness, of course, here it's about saving time, about having a better control about healthy life, and also to have access whenever they have critical time of the disease or any exacerbation. The primary concern was about privacy. So this, I think, is very important to discuss with the patient whenever we're telling them to use the application, about information privacy, and also the social influence. Whenever many patients are using this, this will actually encourage others to use it. So this study was important. It's recent, 2020, and measured acceptance of the electronic patient portal in the Arab countries. And in the conclusion, they concluded that half of the patients are willing to use this, 73% of physicians are willing. And in this study, they showed that the perceived usefulness had a better predictive value than perceived ease to use in this study. Another recent study also published just in January 2021 about digital health to see again in the Arab countries the activity of telemedicine, digital health in this part of the world, in the Middle Eastern countries. And again, they start by saying we don't have a lot of data, we don't have a lot of publications about this because of the lack of innovation in the field of digital health in the Arab countries. Of course, this is changing now with the COVID era, and about the telemedicine research in the Arab countries. So if you see in this publication, the pattern of publications about mental health had boomed basically starting the year 2020, with much more publications in the 2019-2020 compared to really nothing before the year 2000. And in this paper, it was interesting to see the gaps that also can be educational for us in the digital research space, about how can we fill these gaps. So there was in this publication talking about a lack of controlled trials of medical devices, algorithm, telemedicine technology in hospital centers in the Arab world. And they wanted to estimate the precise effect size of this technology to really help more research to be conducted in that field in the Arab world. Cost effectiveness studies are needed to measure really whether digital health is cost effective and whether it is worth doing this program. And again, there was concern about ethical consideration. This is very important because I think any digital health or application that we need to use should adapt to the culture and ensure information security, again, confidentiality and privacy. In the details of this paper, when they talk about culture, they talk even about gender difference, about the privacy, etc. And I think this is very interesting, especially in this part of the world. Other gaps, it was the importance of improving e-health literacy and readiness to learn and to use, and really acceptance of information technology, whether by physicians and by the general public. And also, very interestingly, and we just talked about the help of residents who can help us, the medical resident, in developing these tools, and probably should be part of undergrad and postgrad curriculum to ensure really in the future physician competency in that domain. So another thing that was concluded in that paper was that really the Arab world should develop policies and roadmaps to implement more the digital health programs. And definitely the collaboration between the Arab countries is very important, because these countries cultural similarities, and whatever obstacles or problem that we will face here, they may face them in other Arab countries, and this actually the collaboration would help to outcome these gaps. So in conclusion, I think we all know that the COVID pandemic was a disaster. It had many negative consequences on all of us, but I think if we want to look on the bright side, as always, we have to always take to learn and take lessons from every crisis. I think this pandemic opened the path for digital health acceptance in all countries, and you see in our daily practice here in Lebanon, we have more and more people accepting online consultation, accepting the use of digital health. active participation of patients is very important in allergic disease. It leads to better care and better control. Most importantly, allergic rhinitis and asthma are not static disease. They are dynamic chronic diseases. Continuous monitoring of symptoms is essential, and I think the mask air application gives us a great opportunity for patients and physicians to better control these dynamic chronic diseases. I would like to thank you again and welcome you to this interesting webinar. Thank you.
Thank you, Professor Carla, for this nice introduction. I definitely agree with you. Mobile health is here to stay. It's going to develop very fast as we move ahead. Before I introduce our next speaker, I just want to let the audience know that please, you can post your questions after each talk. I encourage you to post it as soon as possible so we have a chance to sort through them. Also, if you have an urgent question, you can raise your hand and we can try to get you live to give your question orally. Also, I would like to remind everyone that this presentation is recorded and will be available for 1 month on SciencePRO website. You can also tell your colleagues who did not have a chance to attend that they can view it that way as well. It's my also distinct pleasure to introduce my good friend and colleague, Professor Philip Rawadi. Philip is the director of the Allergy Center at the Eye and Ear University Hospital in Lebanon. He's serving the current presidency term of the Pan-Arab Society of Allergy, Asthma and Immunology, and he's an active member of the House of Directors in the World Allergy Organization. Dr. Rawadi has been the leader of this mask air project in Lebanon that we are launching today. Professor Rawadi, the floor is yours.
Thank you, Dr. Zaytoun, and I want to welcome all my dear friends, colleagues from Lebanon and from the area, and I want to thank you for being with us today. So today what we're doing, we're launching the Mask Air app, and I will have to say that this is the first Arab mobile health application in the world that tracks symptoms and manages the allergic rhinitis and asthma multimorbidity. And in this respect, I would like to thank specifically my dear friend Jean Bousquet for endorsing his baby project to the Lebanese Society of Allergy and to the Pan-Arab Society of Allergy. So what we're doing, we're practicing telemedicine. We're practicing medicine. We're using technology to practice medicine at a remote distance. That has been present for more than 100 years during the days of the telex. And over the past 2-3 decades, that really, we now live in the area of digital health. And we're using, different softwares, hardwares, connectivity, so on and so forth. And probably the best form of digital health is the mobile app that we're going to talk about today. So maybe the first question that comes to you is, why should we have a mobile app? Well, the answer is very simple. The mobile app is there because of high clinical burden of a chronic disease, and doesn't have to be in the respiratory domain, in allergic rhinitis or in asthma. It can be in diabetes. It can be in endocrine problems like diabetes, or in cardiovascular problems like in hypertension. But there are many mobile apps which are within a closed system. They're used within, let's say, a hospital informatics systems, within organizations. But then the better ones are obviously which are connected to the web. And now when you talk about connection or international apps, we have to talk about translation. And it took us really almost a year to redesign and translate all the Mask Air app into the Arabic version and all the correlated literature, the websites, and so on and so forth. So a mobile app is a cooperation and involves multiple stakeholders. Now you have the patient because of his or her unmet need, of course, and then you have the physicians, the academia behind it. There should be cooperation with the mobile app developer, and of course with the sponsor. And Dr. Irani talked about the legal issues. These are genuine, and with the MaskAir app, we're into the global data protection and regulation area. So these are red flags over here. But I really believe that a good mobile app should have affiliation with academia. It should have affiliation with international society, academic societies, and medical organizations across the world. And of course, excuse me, the question is, if this is going to be legislated, then it's going to be looked at as a device, a medical device or a medical tool. And luckily, maybe we have to discuss reimbursement now. Luckily, most of the apps that are present on the net are downloaded for free. And to increase usability, we have to talk about the user friendliness of the app itself. This is something on the shoulder of the app developer. And then the most important thing, I think, is the tools that we're using in these mobile apps. And we're going to talk about this later on. But really, what we're doing with the mobile app, we're using a tool to measure what's going on in the real world. And these tools have to be validated for efficacy in measuring real world data. And the $1 million question is that do mobile apps work? Well, Dr. Irani was talking about cost effectiveness, and I'm going to show you that the MaskAir does really work. So to sum it up, cooperation between 4 stakeholders: physicians, patients, app developer, and of course the sponsor. A 2018 review has looked at 72 apps which are present for allergic rhinitis, and most of them are free. They have received high ratings, and we will have to know that some of these are present for clinical management. They track your symptoms. Others are simply to tell you what's the level of the pollen, or what's the level of the pollutant, like particulate matter or ozone. And some of them are really simply for patient education. This is when the patient comes to you and he asks you questions when he or she Googles her problem, and that can work sometimes against what you would want it to work. Now, there are many proxies that you do use in digital health, and you can do that with you see it on the left, with an SMS alert system. You can do a live phone call, or you can do an automatic phone call. This is when somebody misses an appointment in the clinic or misses a refill for the medication, then there's an automatic response system. And then most brilliantly, you can do it with web platforms and mobile applications, and you can do that in different domains. I've listed a few over here, mainly those who have done randomized controlled trials, and there are hundreds of other observational studies that have looked at that, but I wanted to put only the randomized controlled studies, and they work in different domains: asthma, allergic rhinitis, and the improvement is conspicuous. There's documented improvement in control of asthma, in follow-up rate of asthma, and adherence to medications, so on and so forth. But if you look at the green row, really the MaskAir supersedes all of that, because it doesn't really tackle allergic rhinitis, but asthma as a multimorbidity. And we talk about conjunctivitis right now. This is something to talk about later on. And the trials are not only randomized controlled trials; these are proof of concept studies. And we're going to talk about all those improvements that are noted with the app. Now, of course, a mobile app does not come without a price, and there are shortcomings and limitations. There is absolutely nothing which is going to substitute a physical interview of the patient by the physician. And to those people who say that this is cutting down on our patient or our income from the clinic, I want to tell you that actually it's the reverse. It's improving your clinic proficiency, and it's increasing your patient. Of course, we do have some limitations with different age groups, not only small children, but also adults and older patients in terms of how easy they find it to use it. And environmental exposure data that's available in most of the app are not really not in real time. And MaskAir app has done a beautiful job over here with the Polar project. We'll talk about this later on. And digital health, as we were talking, is going to be the future, whether we like it or not. 5 years down the road is going to be all digital. And at one point, we're going to be faced with the problem of integration that mobile technology into closed systems like hospital informatics systems. And we talked already about data security. Now, for asthma, there are hundreds of mobile apps for asthma, like an allergic rhinitis. Some would serve as educational purposes. Others would give you environmental data. And many of them are for clinical management, and they have also received high rate. Now, let's talk seriously now. Paulina Bravo in 2015 had done a remarkable report. She has done, Cochrane review and looked at many different studies, looking at the benefit of mobile health for patients. And the patient empowerment should more or less follow the three major principles. It should allow a patient to monitor his or her symptoms. The patient should get involved in grading his symptoms every day. The second principle is to give a feedback to the patient of how he's doing, how he's managing his treatment, whether he's self-care or whether he's being medicated by the pharmacist or other physicians. And of course, the third principle is patient education. Now, MaskAir went beyond that. For self-monitoring, we're looking not only at allergic rhinitis or asthma, we're looking at other domains. We know that allergic rhinitis is not simply rhinitis. Asthma is not simply asthma. This is productivity in work, poor sleep, studies. And what MaskAir has done is that it has not only assessed the specific symptoms, but overall global symptoms. And this is very important. All the tools that are present there are validated. They're not simply questionnaires. They're not simply custom-made tools. These are validated tools to work. And the management feedback, beautiful results that you can get with that. You get those nice graphs where you are positioned in one of three zones, depending on your control. We'll talk about this. And in the graph, you can see very nicely in a timeline fashion, how you're progressing. With the education, we know that all of what we're talking about is guidelines based. You would be surprised to know that more than 50% of asthma, of mobile applications for asthma present in the market are not based on guidelines. So that the information is not really true. Now, not only that, but what MaskAir has done is that it has empowered the physician. Now, imagine somebody coming to you and he shows you his or her data, and now you have an idea about what the control level on the left, right? And how that disease is progressing. You can track his symptoms day by day, and you can get the information on what type of medications that he's using. Is he using that properly? And of course, we spend more than 75% of our time taking history. Now you have the history in front of you, and this is office time proficiency. You have data not only on the disease itself, depending on the specialist, but on other multimorbidities like asthma, conjunctivitis. And the benefit of that for research is unlimited. And of course, the MaskAir app is going to include a new platform that really shows you the pollen forecast and the pollutant exposure. So to cap on this, empowerment in MaskAir is not only for the patient, but it is only for the physician. And if you see on the left side, on the bottom side, the pharmacotherapy and the immunotherapy, this is an extremely important issue because it actually summarizes all those diseases, all those research and trials that have been done on immunotherapy and pharmacotherapy. So this is so much interesting that we decided a year back in the World Allergy Organization to look at those criteria. What would be sense criteria or non-sense criteria what would be sense digital tools or non-sense digital tools in allergy and respiratory care. What are the criteria that would make those apps really plausible to the patient and plausible to the physician? And so for simplicity, we have divided this into 4 domains: the patient domain, physician domain, legal, and device. And with the patient domain and physician domain, they must, this should empower, both the patient and the physician. We talked about this. And the legal aspect, we have the GDPR, privacy, statement of confidentiality, and so on and so forth. But this is being constantly updated, and we're really trying to go deep into that. There are also legislative issues, right? So the app is a medical tool. We should look at it as a medical tool. It's a medical device, and it should be legislated. You would be surprised that most of the app for asthma and allergic rhinitis in Europe or in the States, and not only in that, most of the apps that deal with health are not accredited by the corresponding authorities, the EMA or the FDA. So the validated tools the tools for outcome measures should also be validated. We're using a very simple but beautiful tool, the visual analog scale, and we're also using the CARAT, the combined allergic rhinitis and asthma test in those. And I personally believe that an app should have, as I said, an affiliation with academic and non-academic organization. And I don't want to talk really a lot of this. Maybe John can do that, but really the Mask Air app has received the highest recognition as a medical device, and also it was recognized by the OECD last year. Now, with the device, of course, we agree on all of this. That should be user-friendly. It should connect with existing patent records. But we have to remember that these mobile apps are going to deal with hundreds of thousands of data. So we need artificial intelligence to analyze all of that. Multi-languages. We know that there are many apps in asthma that do connect directly to tools that measure your nitric oxide, or to your spirometry, or even to medications, inhalers that have sensors and that would give that can be connected to the mobile app. But most importantly also is geoadaptivity. We know there are certain special climates, like for example, forest fires or desert storms in Arabia, and that app should be really able to adapt to those new conditions. Now, I like these 2 slides because it summarizes pretty much what we have been going through over the past 2 decades with area. Professor Bousquet likes to call it anamorphosis, a beautiful term. He's going to talk about this in a second. But, briefly speaking, area started in 1999 as a combined project with WHO and Galen, and it has went through different updates, different revisions. And in 2010, it was really the first guidelines that really used the grade approach, the grade of recommendation, assessment, development. And the reason for that was very simple. Now, of course, during that time, over 10 years, we always stressed on the physician and on the patient the issue of adherence to the guidelines, of compliance. But we had always the problem of severity. Most of people have looked at their allergic rhinitis as severe. So something should have been done, and actually it happened between 2015 and 2016. And area said, okay, we're not going to spend our time, hammering the patient or the physician with adherence to guidelines. Let's focus on control. And that's an innovative thing that you do. So we're changing the whole concept, and to change something like any business model, you have to manage that change. And this is change management 1. And now we're doing the change, the second wave of the change. So basically that change was according to 2 principles. Now, brilliantly, area has introduced the ICP, which is the integrated care pathway approach. And this is another fancy word of saying that, multiple specialties should be involved with allergic rhinitis and asthma. And that was done in collaboration with the WHO projects called the Airway ICP. And because it is multiple subspecialties, now area is in the pharmacy. And we stress about this issue of multimorbidity, especially because of the new data, a wealth of data that we get from MEDAD. Now, the second principle that area did is that it has introduced information and communication technology in the control of of allergic rhinitis and asthma. And this is part of the personalized medicine. This is shared decision making between the patient and the physician. So this is mask air over here. And now in 2018, mask air went into a twinning with the polar, which is the transformation of technology and data from the pollen sensing mechanism and the pollutant sensing mechanism into the app. Now we are, the app is doing so much good that now we are at a stage whereby we're using real world data to assess the evidence-based medicine. This is the ultimate thing that you could do, and I'm sure Jean is going to talk about this. So the important thing is, transfer of data to the healthcare professional. And this is the basic framework of patients with allergic rhinitis and asthma. They do self-care. Some of them would go to the pharmacy. If it doesn't work, you go to the GP, and then to the specialist. And as we've seen in the previous conference, you'd be surprised to know that in the West, it takes you some 5 to 7 years for a patient with allergic rhinitis and asthma to reach a specialist. And of course, this has redundancy on the emergency visits. Now, what mask air is doing, mask air is intruding into all those different levels. Now the patient has direct access to the app for better self-management. The pharmacist has access to the mask air, and then you're transferring all those data to the healthcare professional. You can see it on the right. It's done simply by a QCR code. And this is the kind of information that you get. You get specific data. You don't get all the data. So you see on the drug name and then the date and the level of control, you see, whenever you're in the green zone, it means you're controlled. In the orange, you're partially controlled. Now, this is the data of a patient with allergic rhinitis who happens to be also a physician. And you can see, under level of control that most of the time, this patient is more or less well controlled. And you can look at the dates, where he has recorded. You can compute over here the pollen, you can compute the pollutant, the immunotherapy, so on and so forth. But look at the drugs. You see that that particular patient is not adherent, although he has a well-controlled. And some days he's on one medication, and other days he's on two, and in other days he's on no medication. So this kind of gives you the perspective of how we're looking at all of that. And of course, the next generation area guidelines, I know Jean is going to talk about this. We're going in zillions directions, in immunotherapy, we're going into aerobiology, biodiversity, and so on and so forth. So the mask asthma, this is data from 2018, and area has more than 88,000 score on asthma, and recently in 2020 it performed so well that got recognized by the OECD, and this is real commas now is in the context of the digital single market strategy. This is a beautiful platform that's going to integrate how you look at all those patients with asthma that use the mask air. Again, I hope Jean is going to also elaborate more on this. So let's go to the mask rather quickly. Now you have it on, I have it on my screen and I click it. So you get a welcome note and then you get into the main menu. This is daily follow-up on top. You get the results, you get the personal file, and then you get, you set the app to remind you every day to score your symptoms. And as you know it, this is a simple visual analog scale. With your finger, you can move it right or left, depending on whether your symptoms are not bothersome or bothersome. And this simple motion takes a second, and it adds significantly to the way we're going to manage, those diseases. And it goes into global symptoms, for example, like here, it goes in specific symptoms. This is for rhinitis, this is for conjunctivitis, and this is for asthma. you rate all of that. And because allergies are not organ-specific, they're general, they're systematic, so we have to test also for work productivity, how much is allergy affecting your work, and then what are the different treatments that you're using. And then before you go, you get a simple tip, you read it, and this is the result. So this is patient and physician empowerment. You can see on below the different dates, and then you have 3 zones. The green zones is a well-controlled, you know, the middle is partially controlled, and the up one is poorly controlled. And every time you score, you get a bar over here. Now, this is so interesting because let's say, for example, as you see on the left, you get 3 consecutive days where you're in the poor control zone. Then you see on top that the message, the app is going to send you a message telling you that you're not controlled and you should check your physician. Now, this is also another interpretation of the results. Imagine a patient coming to you and he's showing all of this on a simple app. You know, that's incredible. And then you have those different graphs for all those domains that you're testing, academia, you know, work productivity, so on and so forth. So, and then if you go again on that menu, I want you to look over the personal file, and then you go and do that only once. You log that, you log the data, and then it asks you, do you have rhinitis or do you have asthma? And then it asks you again, are you on any immunotherapy? And you say yes, and then you get, you know, you log in all the pollen that you're allergic to. You know, people are conducting studies, epidemiological studies, to know, you know, who's allergic to what. And this is information at the tip of your finger. And then it asks you, did you take your immunotherapy? Have you taken your medications? This is when it memorizes the medications, asks you, do you want to add other medications? What's the route of administration? And then you have a list of all those medications that are present in Lebanon locally or in any other Arab area. So this is again to show you the impact of MaskAir app into immunotherapy, because once you have all these data, this is going to expedite your decision and it's going to make you sure if that patient is doing well or not on immunotherapy. And then you get all those data in and out of the season. Now, most importantly for us, you see on the right, this is an app that stratifies your patients for any trial that you want to do. If you want to assess immunotherapy, you know, is he doing well on immunotherapy? If the immunotherapy is stopped, you know, a tremendous amount of data. So what we learned so far in terms of adherence, we know now that there's poor adherence to physician's prescription. And, you know, the data from MaskAir tells you that if you prescribe a patient 3 medications for allergies, he's going to take it for a few days. If you prescribe 2 medications, maybe for 5 days, at best 1 week. If you prescribe 1 medication, he or she is going to take it for 12 days, at tops 2 weeks. So patients self-medicate themselves. And if they control, they stop therapy. And if they're not controlled, they take on-demand therapy, or they switch therapy from one medication to the other. And of course, there's behavioral science of this. We talked about this in the previous conversation. Now, I put this to show you 2 things. You know, the type of data that we get from the MaskAir. You see the VAS level. Anytime you score on that app, you get a VAS data. And also, you see on the left, whether you're during season or outside the season, whether you're treated or untreated, most of patients with allergic rhinitis have bothersome symptoms. This is scary. And also, the other scary thing is that if you look whether during season or out of season, treated patients are performing worse than untreated patients. So control with pharmacotherapy is an issue that we have to look at. Now, we know that monotherapy with oral antihistamines is has a poorer control than intranasal steroids, you know, and whenever we're poorly controlled, we're shifting from monotherapy to multitherapy. But then you say, wait a minute, you know, the guidelines have said if you have poorer control, you have to move from monotherapy to multitherapy. So we're really trying to look at all those and trying to correct, you know, all that with real world evidence. Now, I've shown this also to tell you that the visual analog scale that we use does really work. And you see on the right side in orange are the app users and their controlled patients. And on the blue is for non-app users. And you see whether you're talking about global symptoms, nasal symptoms, ocular symptoms, and asthma symptoms. app users, the VAS that you're using in the app does correlate with those who are not using the app. So this is a system that works, and more of that, those who are using the app are doing actually better in VAS than those who are not using the app. And in the app, in asthma, we're using the asthma control test, and you can see over here that it also correlates very nicely with those who are not using the app. Of course, this does not come without a price. As I said, mask air users are select patients of allergic rhinitis. They're simply patients who are using the app. And there are other confounding variables and also some data limitation that we can talk about. So I'm going to take only 2 minutes to talk about our action plan in Lebanon. So now we have it. We have the website completely translated in Arabic. We have education material on YouTube, and we have the app that has been a few days back fully tested multiple times on Google Play and App Store, so it's working beautifully. And we need to spread the news. We need to involve KOL in using the app. We need to involve resident training. We talked about this. I've already started instructing my resident, to spend 10 to 15 minutes with each allergic patient. They explain to them the benefit of the app. They actually help them to download and to register. It takes 10 to 15 minutes to do that. And if you get, 14 recordings, that would be awesome. And we have already submitted a preliminary study proposal. We're trying to look at all those knowledge gaps that we have in Lebanon. I know we do have some epidemiological studies, but we really have no idea about, multimorbidities, severity control, so on. And, the good thing about it, and I've always loved in this area, is inclusive of everybody. Everybody who likes to work is going to be recognized, whether he's a resident in training or a KOL. The mask study group is several hundreds of physicians in more countries. We plan also to make Lebanon as a area care center of excellence. There are more than 130 centers, and we have to work on all of that. So finally, I would like to say, I have always believed that knowledge is in the air. So go ahead, use the mask air. Let's seize this opportunity and really use this app. It's the benefit for the patient is going to empower your patients, going to empower the physicians. It's going also to contribute significantly to the knowledge that we have on allergic rhinitis and asthma. Thank you so much, and I apologize for taking maybe a few minutes of your time.
Thank you, Philip. Thank you very much. This is indeed very exciting, and really, again, I can only say really congratulations to you, congratulations to all of us for this exciting achievement, putting Lebanon on the map once again, despite all these difficult times that we are going through. I'm sure there's going to be a lot of questions, if not today, to follow up in the near future on the use of this application. We are very excited, and congratulations again. Last but not least, it is my distinct pleasure and great honor to introduce a man who needs no introduction. Professor Jean Bousquet is the founder of AREA, as you all know. He has instituted with excellence information and communication technology, ICT, as a research and management tool in allergic respiratory disease through several programs, including what we are discussing today. He initiated this internationally renowned mask air mobile application, which, as I said, is being used in over 33 countries. And he's here with us today to help us launch this exciting event. And he will talk to us about the integrated care pathway approach in patients with allergic rhinitis and comorbidity. Professor Bousquet, welcome.
Thank you. Well, ladies and gentlemen, I'm a fan of Lebanon. As you know, we have had plenty of Lebanese fellows in my group, and some of them have been particularly brilliant, like Adnan Rajawi, but many others. So when I'm coming to Lebanon, I feel at home. And I feel with friends. Well, the group here, Fares, Carla, are excellent. But I've had some interaction with someone who's absolutely remarkable, is Philip. Well, Philip Ruddy, I met him the first time, I didn't know before, but I met him the first time, it was in South America, and he gave a very interesting presentation, because he gave a presentation on some of my papers. And I realized that my papers may have some other interest. So he was able to find in my papers what I didn't find myself. And I think this is quite rare to be said. So when Philip approached me to say, I want to do ARIA in Lebanon, I said, okay, let's do it. And then Fares, Carla, and others came, and we had a meeting in the US, and we decided that. And I am really delighted today for this launch. It is the first Arabic mask. And this is excellent, because Lebanon is going to lead the field. And since you're also leading the Pan-Arabic Allergy Association, I think this could be excellent, and this could be a vehicle to show that Lebanon is really a big country. I know that today you have difficulties. I know that Lebanon is a small country, but the people in Lebanon are really excellent, and thank you for that. So what I want to say now, I want to go to patients first, integrated care pathways. Well, patient first, you can add this. On the left-hand side, it is business. In the middle, it is chaos. And in the right, it's possibly a bit difficult. I prefer patient first like this. You have the School of Athens with Raphael Lowe, and Aristotle was in the center. And you have also Hippocrates. And these two great physicians, the first real doctors, told us patients first. And now we need to go a bit beyond with mHealth. This is why I took this cartoon. A year ago, we published a very interesting paper in Nature Review, top journal. And what we said is the following. The delivery of cost-effective modern health care is challenging for the management of allergic rhinitis and asthma, as management is often dependent on specialists and supporting services, and it's becoming unaffordable and with delays. How long should a patient wait before going to see you? Sometimes it is in months. So we need to have something which is in between. Accordingly, innovative solutions centered around the patient and often based on mobile health are required. Authorities should be supported for the transformation of health and care towards integrated care with organizational health literacy for allergic rhinitis and asthma. And I'm delighted to tell you that next week we should be accredited by OECD, the organization, the Economic Organization for Development and Business, and DG Santé, which is European Union. So we will be able to tackle policymakers. And I think that this is very important for Lebanon because allergic rhinitis will be leading the field. We need to have a global allergy simple solution. And we're going to work on it to make it simple and to make it based on the patient, mHealth, and the physician. Mobile health could be used to optimize an accessible and affordable treatment in stratified and participatory patients with allergic diseases to provide change management. So I would like to discuss 6 points in my presentation. The title is Patient-Centered Care Pathways. I'm going to start by ARIA. I think it is one of the best evidence guidelines, but it is centered around healthcare professionals, even though we had patients' organization at the very beginning. So it is yes, but. What we need is the patient-centered using mHealth, and this is must. In order to develop next generation guidelines and care pathways, we should go from rhinitis to asthma for change management. Well, what is ARIA? In 1990, I saw a lady from Morocco. I still remember this lady. She had severe asthma. I gave a fantastic treatment for asthma. FEV1 went from 50% to 100%, but she was not satisfied because now I have rhinitis. And this told me that I needed to go beyond the lungs to the nose. Well, what we did epidemiologic studies. This is the big European Community Respiratory Health Survey. We did mechanistic studies, and 10 years later, we started ARIA, because this was essential. ARIA is allergic rhinitis and its impact on asthma. I was the chairman of GINA, and I was said, well, you know, asthma is between this and rhinitis is above. And I said, well, but my patients are not stratified by level, but they are a full patient. And this is why I started ARIA, allergic rhinitis, and its impact on asthma. So the ARIA initiative was developed as a state-of-the-art for the specialists, the GP, and the healthcare workers. We forgot the patients, and all guidelines have forgotten patients, whereas this is the patient who should be at the basis of the guideline. To update knowledge on allergic rhinitis, to highlight the impact of allergic rhinitis on asthma, and this was a great success, to provide an evidence-based document on diagnosis, methods, and treatment. But also, what we wanted to do, it was a global approach, and we wanted to assess the magnitude of the problem in developing countries and to implement the guidelines in these countries. And this was an essential step, which was missed by GINA as well. So the first step was the development of an evidence-based guideline during a workshop endorsed by allergy, respiratory, and pediatric associations to produce materials to improve delivery of care to those with rhinitis, in particular pocket guide, to implement ARIA guidelines, and to make recommendations for healthcare professionals. Again, healthcare professionals. We didn't pay sufficient attention to the patient. Well, this started as a WHO project, and it has been continued by the Collaborative Center on Rhinitis and Asthma, and now it is a GARD demonstration project. So it is WHO with EU grants. We have had 10 EU grants for mask and ARIA. What we did, we published the first paper, 2015 citations. We published an update. This is the best cited paper in asthma per year. We then changed the system from an order system to the grade approach, and this was the ARIA guideline, the revision 2010 and 2016. So we have done guidelines, and all of them have been largely published and disseminated. We also had a pocket guide with 52 translations, and here Anna Bedbrook has been essential. Well, ARIA is the state of the art. Yes, but, well, first of all, guidelines are based on randomized controlled trials. And of course, randomized controlled trials are the gold standard for assessing efficacy of treatment interventions. However, they are designed to answer regulatory questions, which may not be the questions the patient are asking. And they are tightly defined against these scientific questions. The problem is that they are not reflecting the general population. We did a study and we assessed the patients who could be enrolled by primary care physicians when you take loratadine and cetirizine requirements. And in fact, only 7.4% of patients consulting primary care can be enrolled in randomized control for allergic rhinitis. So over 90% of patients are not eligible. The second point, and this is a GSK slide because I took it like it is, adherence to treatment in randomized control trials should be over 70%. Patients who are less adherent are excluded. And you will see later that this 70% is quite hard to achieve. However, guidelines are effective. And this paper was so innovative that it took 3 years to be accepted. What we did, we used quality of life to assess the control of the disease. And this was the first time quality of life was used. And secondly, we didn't randomize patients, but we randomized physicians. Half of them used the consensus treatment and half of them the free treatment choice in 3 countries with 3 languages. It was not ARIA because it didn't exist at that time because the study was not in 1999. What we found, it is that in yellow, patients are better with free treatment, but they are far better and significantly better with a consensus-based guideline. So on one hand, the guidelines are not sufficiently close to the patients, centered around the patient, but on the other hand, they are effective. And this is me giving a presentation on ARIA. I'm going to give you a secret. I've written ARIA, but I am not able to follow ARIA guidelines for my rhinitis. This is a problem, because if the guy who is the ARIA leader cannot follow what is proposing, it is that we need something else. And we need an approach centered around the patient. So I need to change Jean Bousquet from a KOL to a patient. And when I change Jean Bousquet, I'm not the same guy. And what I need is to follow the patient. So we have now proposed mHealth patient-centered approach, and this is MASC. MASC stands for Mobile Airways Sentinel Network. The concept. Well, first of all, a care pathway. When a patient is having symptoms of asthma or rhinitis, if the patient doesn't take a treatment, they go to their shelves and take whatever they have. And very often it's not the best treatment. So this is self-care, which needs to be improved. Then, at least in my country, they go to the pharmacist, and the pharmacist gives some OTC medications. They are often very good, but you don't have all the formularies. Then they go to the GP and they end to the specialist 7 to 10 years later. We need to shorten this and to stratify the patients who are going to see the specialist. And this is what we proposed in 2014, and in this paper, there is even a Minister of Health. So again, I'm starting with this lady. And this lady, it took 26 years to go from what this lady told me to what we needed to do, that is to say, care pathways, implementing emerging technologies for predictive medicine in rhinitis and asthma across the life cycle. So you see, it takes time to understand what you need, but every other guideline has been focusing on physicians and not on patients. First of all, we needed to know whether the guideline was, well, whether MASC was important or not. So Aramanto did a study by JavaScript programming, and he studied 1,900 apps which are available on Android and iOS or iOS. And from these 1,900 apps, only 21 met the criteria of management of rhinitis. Among them, you have 4 apps which can be used. Allergy Monitor is in 14 countries. Last update 2018, published on methodological validation 4 papers. All medications. Galenus, it's a rhinosinusitis app, not validated in rhinitis. The current version is not available yet for all countries. So I don't know exactly what it is. What I know about because it is a replication of MASC-R, but it was a replication for rhinosinusitis. So it is not fully acceptable for rhinitis. MASC-R, we have 25 papers published, and in total we have 80 papers in 17 languages. And the Poland-Austria app is very interesting, but it is more for Poland, and I don't think it is very relevant for Lebanon. So, since I wanted upfront to have data or the app used at least in 18 countries, we started by 18 countries, we needed to have a very simple tool. The simplest tool is a visual analog scale for pain you have a single analog scale, and with this analog scale, you know what is the severity of pain and how the treatment is working. So we use the same from not at all bothersome and extremely bothersome. And it was the finger approach, because you only need your finger in mask. So mask has been, well, now this is mask, and we have many, it is, sorry, version 4.1. So Mask Air is free on Android and iOS. We are in 28 countries, 20 languages, 40,000 users, 360,000 days. It is fully GDPR. And it's based on 4 questions only. That's enough. You don't need more. Overall, how much are your allergic symptoms bothering you today? How much are your nose symptoms bothering you today? How much are your eye symptoms bothering you today? How much are your asthma symptoms bothering you today? With these 4 questions developed with patients, you have everything. Well, other apps have tried to replicate what we have done, and they're using questions which might not be understandable to the patient. The strength is that you have all medications used in your country. This is customized to your country, so we can compare different countries. Now, when you have an app, you need to know whether it's good or not. Well, the best is, can you find new allergic phenotypes? And with your hypothesis-derived data, can you show that these data are replicable in epidemiologic studies? This is what we have done. We have compared here, it's only 32,000 days. Now we have data for 250,000 days. And you see that when you look at VS nose and VS asthma, you have 4 groups. First of all, you have people with no symptoms. There are very few patients with high VS asthma and low VS nose. So the concept of ARIA is considered. And then on the right-hand part in red, you have patients who have almost 100% replicability between nose and lungs. These are the multimorbid. And in green, these are only with nose only. And if you go to conjunctivitis, you have the same. So it appears that there is a new population in red, which is a multimorbid, which is including asthma, rhinitis, and conjunctivitis. Now, we can say that conjunctivitis and rhinitis differ, because with DSI, you see in green and red that the people are not the same. What we found here, I'm sorry for the quality of the slide, but I couldn't make it different because it is on the screen. So what we found, it is that rhinitis is increasing in severity from rhinitis only, rhinitis and conjunctivitis, rhinitis and asthma, or rhinitis, asthma, and conjunctivitis, both for VS Global and for VS World. This suggests that, in fact, there is a specific phenotype, which is the multimorbid polysensitized phenotype. Now, can we reproduce this in epidemiologic studies? Yes, and this paper is very interesting because it was accepted the same month as the former paper with exactly the same data was published in the same journal. I think it's a Guinness Book paper because usually editors hate to have a reanalysis of data. Well, very simple. We didn't consider conjunctivitis before, and we considered conjunctivitis now. And you can see here that the sensitization profile differs considerably. So it is clear that conjunctivitis is not similar to rhinoconjunctivitis. And this is a message from us. The next point is that according to the prevalence of eye symptoms, the severity of rhinitis differs. And this is again confirming the hypothesis raised in mask. Well, here I sent the letter to Dr. Amaral in Portugal, and I told her, well, you should analyze conjunctivitis. Usually she replies within a day, and here It took 4 days for her to reply, but she sent me the data. And the data extremely interesting. But this one is even more interesting. And no one would have thought that. And now we have replicated in 3 different papers, these two studies. When you assess the severity of asthma, using latent class analysis and count to analyze the ranking, the first symptom which matters is ocular symptom. Can you believe that for asthma, ocular symptoms are the first to consider for the severity? If you don't have ocular symptoms, usually asthma is less severe than when you have ocular symptoms. So asthmatic participants commonly have conjunctivitis. The severity of nasal symptoms is associated with conjunctivitis, and conjunctivitis is the first criterion to be considered. We then now went to genomic studies. So, you know, this is MEDAL, Mechanisms of the Development of Allergy. And we studied multimorbidity and rhinitis as a single disease. We didn't find any gene associated to asthma as a single disease or atopic dermatitis as a single disease. And you can see that the black and the red are totally different. The black is rhinitis as a single disease, and there is a line of red, and the red is multimorbidity and the line of green, of gray. So we have 2 different diseases. And in fact, we know now that rhinitis alone is associated with toll-like receptors, whereas multimorbidity is associated with polysensitization, and it is with ILC2, IL-33, and IL-5. So from MASC, we're able to go to epidemiology and genetic studies. We have another approach for treatment. First of all, adherence. You remember that I told you that randomized control trials needed to have adherence at 70%. Here, we took 7,000 patients, 900 of them were reporting between 7 to 30 days, some more, some less. And among these 10% of patients, or 12%, only 5 to 12% were adherent. So clearly, adherence to treatment in MASC is far lower than 5%. And a study with 70% adherence is not fully relevant. Secondly, 50% of the patients are using automedication and OTC medication. And this is clear. And I will show you something else later. The next point is that I wanted to know what the allergists were doing. So this was a study which took me 2 minutes to get the data, 2 hours to write the paper, 2 days to get it accepted, and 2 weeks to get it on PubMed, and I'm not joking. I asked to 300 people in the room using touchpad, how many of you are allergic? 102. How many of you use the medication during the anti-pollen season? 0. So I am not able to use ARIA guideline. The physicians are not able to use ARIA guidelines, and the patients as well. ARIA guidelines have helped us better understand the disease and to better propose a strategy. And from this strategy, the patient is doing what they want. And we need to account for that. Well, this slide is a bit complex, but I want to discuss this in detail. We had the first study with 3,000 patients, a second study with 10,000, a third one with 18,000, and the data absolutely similar. When patients are not treated, they are very well. Surprising, no? Because you might think that when patients are not treated, they are not well. Well, in fact, no, they are very well. When patients take a single treatment with either azelastine fluticasone or fluticasone furoate or mometasone furoate, they are also very well. When they take cetirizine, it's less good. And when they take desloratadine, it's even less. But when patients co-medicate, that is to say, take more than one medication, they are not well. This is against the guidelines. the guidelines tell you increase your treatment to be better? Well, the answer is on the right part of the slide. When you are in green for fluticasone fumarate or mometasone fumarate, there are only 30 to 40% of patients, or days, sorry. When you are in green with azelastine fluticasone, you are 60 to 70% of days. This means that when patients are well, they do not need another medication. When they take a medication and they are well, they don't need co-medication, and they co-medicate when they are not well, and often they cannot be controlled. So, again, when patients are well, they do not take a medication. They increase the medications to be controlled, but many patients cannot be controlled. And these observations do not accord with guidelines that propose to increase treatment to achieve control. Data which have achieved last week. These are the medication patterns across 2016, 17, 18, 19, and 20 in 3 different countries, Italy, France, and Germany. You see that there are peaks. So there are seasonal exposure, seasonal peaks of medications. And this is corresponding to the pollen season. However, most patients use oral antihistamines in blue or co-medication in red. This is surprising because guidelines propose to use intranasal steroids or azelastine fluticasone if the patients are not well. So patients do what they want, and they do exactly the same in all countries. However, prescriptions in all countries are different. And this is a paper which is in press. And this is extremely interesting because patients do not do what they should do. They do what they want, and they treat themselves according to their symptoms. And it is the level of symptoms which drives the medication. This is totally opposed to guidelines. This is why we need next generation guidelines and integrated care pathways. What makes the next generation guideline unique? Well, first of all, this is the first great guideline integrating real-world data from mass and Chandler studies. There is no other one in any other disease, so we are again leading the field. They provide a clear strategy to identify the approach to treatment, and the treatment approach is based upon visual scale, very simple. It is the first guideline to provide a specific treatment recommendation based on current treatment, VS score, and exposure to allergen. And this has been done by consensus, and we are starting now to show that it works. I'm again coming to this graph. When the patient needs a treatment, it's not only a physician treatment, but it is self-care, the pharmacist, the GP, and the specialist. And this is the paper, which I think is our the latest very interesting paper. Well, I'm indicating what GREAT is saying, what real-world evidence is saying. Oral antihistamines, and this is not confirmed by real-world evidence yet, because the studies are quite old, but they are less potent than intranasal steroids. We all know that. However, they're effective in some patients, and we're going to show this, because some patients only need antihistamines and do not need other treatment, and many patients prefer an oral treatment. So they should not be thrown out. They should be considered in the treatment strategy. Intranasal antihistamines, very clear. They are not more effective than oral antihistamines, even though the general practice of the US are saying that they should be given as first-line treatment. But you know, very few people use intranasal antihistamines alone in mass care, yes. I think it is 0.3% of days. But they are effective within minutes. So some people may want to have a very fast efficacy. I think that when you need an intranasal antihistamine, it's better to add with intranasal corticosteroid. Intranasal corticosteroids, they are the most potent medication, first-line therapy in moderate severe rhinitis, but the onset of action takes a few hours, and people use the medication when they're not well, and they want to be well immediately. Oh, sorry, there is one slide missing. It is intranasal steroid plus intranasal antihistamine, and this is potent medication, first-line therapy, and they're acting very fast. And this is the major strength of the problem, acting very fast. So we should have a different hierarchy of treatments according to next generation care pathway guidelines. Oral antihistamines, not very potent, but many patients are sufficiently treated, at least for many days, and they like oral. They're quite safe, except the first generation, so they can be given. Intranasal antihistamines, they are less effective, and except in the US and possibly in other countries, but mostly in the US, they are recommended as first-line treatment for intermittent rhinitis. Intranasal steroid, they're effective but slow. If you add oral antihistamine to an intranasal steroids, there is no efficacy, no benefit. And for me, an important medication is PRN, and if needed long-term, intranasal steroid and intranasal antihistamine, because they are most effective and rapidly acting. You know that now there are two in the market. I don't know in Lebanon how many are there, but there is a second one which is coming. So we didn't want just to go to rhinitis, and this is asthma. This is a study in 13 patients with severe asthma. And you can see that some patients are in green, others are in green and orange, and others are in red. So these patients are under biologics, and our app is able to assess the severity, daily severity, and the daily control score. This is the adherence. The adherence in severe asthma is much better than in rhinitis because people need that treatment and they use it. Interestingly, there is a highly significant correlation between VS asthma and dyspnea. So our visual scale asthma is pretty good. And there is a good correlation with allergy symptoms, nasal symptoms, eye symptoms. Interesting, work and sleep. And now we're going to use sophisticated statistical analysis within the next days to assess work and sleep and to see whether the trajectories of asthma VAS, sleep VAS, and work VAS are similar, because we may show that, in fact, people are not working well when they have severe asthma and they do not sleep well. And this will be very important for medications. And finally, I want to show this. This is our future. With OECD, we want to build a platform for shared decision-making in asthma. With MAVSCare and CARAP at the screening, to assess asthma and multimorbidity in the waiting room. When the patients arrive at the physician office with a QR code, the physician gets all the information and is able to prescribe a treatment, which will go into the app with the QR code. And then during the follow-up, we'll have the pollen season, pollution, climate, and we have a paper which has been recently published showing that we may identify seasonal asthma and the winter season in asthma. Then the app will have a daily follow-up for adherence, control, medication, and environment, and send alerts to the patient for environment, decreased control, increase in medication, and advice for urgent medical need. So this is what we want to do in the next 2 years, and I hope that we'll be able to complete it. So what we need now is to do a change management strategy. Allergy is the prototype of a digitally enabled patient-centered care pathway. And you in Lebanon, you can lead the Arabic world on this. And this is why I'm so happy that my friends in Lebanon are going to do this. Secondly, the OECD will be able to include the digital transformation of health. What we want to do is shaping the digital single market of the EU and to do change management. Thank you.
Thank you. Thank you very much, Dr. Bousquet. Really, we cannot thank you enough for your great service and your great contributions over the years and decades to the world of allergy, and you are still doing that. We have run over time for our allotted session. Maybe we have a couple of questions. I wanted to ask you first, from your experience across, from all the data across all the cultures in all the countries, are there any distinct differences across cultures or across differences in the way patients report data or get or self-treat?
The simple answer is no. People change their medications when needed. When they are not well, they change their medications. And in the latest data, the median VS score, when the patient is not treated, is 7. When the patient receives a single treatment, it's 14. When the patient receives 2 treatments, it's 16, 3, 22, 4, 27, and over 4, it is 52. So patients increase their medications when they're not well. And this is what we do. Those of you who have allergic rhinitis, it's exactly what you do.
Great. Dr. Rawadi, where do you see us in Lebanon? Is this application ready for use right now, as of today?
Yes, we have actually tested all of that on iOS systems, in Android systems. And not only that, we're testing this and the test has been very successful. We have done this on all different cell phones available in the Android cell phones and in the different iPhones on that. So it is readily available, freely downloadable. You can do, we have already started with it a few days back, and I would also urge everybody to start using it. We're ready. I'm always available for any questions concerning this. You know, this is a prototype. This is something at the very onset of the project. And I ask people who do really notice some glitches on that to report it directly to me. But I would say that the is very well operational now in Lebanon.
Who should patients talk to when they have a glitch or have a question? Their physician, or will there be like a central command for this application?
Well, for now, I'm going to ask everybody who has a glitch in that to call me directly. I don't anticipate, you know, a lot of problems with that. We have done extensive reviews with test flights, and I think we're at 99% of full operation with this system. And you know, I would like also to remind physicians and trainings that we have listed all those medications that are currently endorsed by the Social Security. So all the list of medications that are present in the pharmacy are also listed on that. We actually plan, and this is something that we need to discuss through LSAI, we need to really plan another meeting to really look at this very carefully and see how we can improve the compliance or the usability of this by the patient. So we're going to have another action plan, hopefully at the level of the Lebanese Society of Allergy.
Speaking of compliance, I have a question perhaps to Dr. Bousquet regarding encouraging patients to log in on the application on a daily basis. In your experience and the data from across the world, how much of an issue has that been? And how compliant are patients? And what do physicians do to encourage patients? Is this just an individual physician-patient relationship?
Excellent. Well, in fact, when patients download the app from the internet, they use it for 3 days. When patients download the app from a doctor, some patients do it for the year. So I think that when physicians, well, allergists enroll, the compliance is far better.
If I may continue for Professor Bousquet, are we worried that patients will feel more whenever they are more severe or feeling more symptoms?
Of course, people use the app when they are not well.
Okay.
They take the medication when they're not well, and then they say, "Oh, I have an app."
Okay. but this should not result in bias or.
Well, I don't think it's a bias, because what you want to know is how bad the patient was during this allergen exposure.
Okay.
You don't care whether the patient was well, but we are interested to see that the patient was not well. And so, since with the QR code, you can see immediately that what was happening, then you will see that in some days, the patient was not very well. And you will see what is the treatment. So you will be able to adjust the treatment of your patient.
Okay, thank you. And if I may ask a question to Philip about like the data, if you want to explain to everyone's listening that where will go the data or who will collect it, please.
Well, the data on mask air is fully protected for patient privacy, as we said, and for data collection. At one point, the app is going to ask a geo-localized question. Patients are free to note which geographical area they can do that. But actually all the data goes through a centralized system, and it is at, I believe, at Kiomed, which are the mobile app developer. Now we have to understand that what we're dealing with is a huge amount of data. We're talking about hundreds of thousands of VAS scores, and the system should be able to integrate this and analyze the data in a machine learning method. So yes, the data goes to a centralized headquarter, which is fully protected.
Well, what I would like to say is that we know in which country the patient is, because if you are from, for example, from Turkey, you cannot download an app which is from Lebanon, and vice versa. So this is country specific. Then the patient can accept to be geolocalized or not. So if the patient accepts to be geolocalized, this is also fully protected, and we have published even a paper on that in the World Journal, by the way. So, this is fully protected, and we are following the GDPR, so the protection law from Europe, and we are so secure that we publish the paper in French. So you can have the paper in French. I know that you read French. So you can have the paper in French. That is to say, I don't think there is any other app which has published the GDPR.
Dr. Rouadi, do you have I know now you are the current president of PASI. Do you have a game plan for when to introduce this to Arabia, either through PASI or through other national societies? When do you think that will be done? In 6 months, year? Do you have a period of time in mind?
Well, that's a very good question, because we wanted, when we discussed this with John, we wanted this Lebanon to be a pilot study or a kick-off country for Arabia. And, we think we're probably as good as other well-developed countries in testing this according to our culture and according to our data. So the plan today is to test it in Lebanon. We really want to look at what's going on in Lebanon. And, I want to open a small bracket over here, because what I want to say is that we would love patients to be compliant on the app on a daily basis. But then, you know, I've tried it myself over several weeks, and I don't find myself available at all times, you know, when I get a reminder from the app to fill the data. So I do understand that, you know, we care for VAS -day recording. It doesn't really matter, you know, if you're doing well or you're not doing well, as long as we're, you know, reporting on that, that's a good thing. Now, once we test this in Lebanon and we do have enough data, you know, that was something, you know, we discussed earlier on. If we are around maybe 24 or 25 KOL, or maybe more than that, we would be surprised, you know, by the number of KOL participating in that. And, you know, my plan is if we really get residents actively engaged in that, you know, that would work very well for us, because we understand, you know, KOL are very busy, you know, they would, you know, they have time they spend in the office, and the resident is there, he can do everything. And of course, dedicated KOL can do also that in their spare time. They can do it on themselves, for example. I'm personally, I'm allergic, and I find that app, you know, working beautifully for me. Now, if this works very well, you know, let's say between 9 months to 1 year, then through the PASA, the Pan-Arab Society of Allergy, and, you know, we're going to launch it in Arabia. We have already discussed this with, you know, with John and, you know, with Kiomed, that, you know, what we're trying to do is, Lebanon is a kick-off country. You know, our plan is really to extend it through Arabia. We don't have any knowledge on the, you know, outcomes of management of allergies in Arabia. That would come really very handy. So yes, we would probably test it for maybe like a year. It really depends on the amount of data that we get.
But may I make a suggestion?
Sure.
In October or November, we review everything, and possibly we may start early January as a pan-Arabic country to see, so you can already test with your friends. In the big countries, don't go to the small ones because we don't want their funding, but in the big countries, who would be interested to do it? And we can discuss a few people, you have people, so you know, what could be done? Well, for me, what is important, it is that Lebanon is the leader in Arabic countries, because Lebanon has brilliant people, and you will show that it is a model that can be used in every Arabic country, you know, country using Arab as
Well, let me say we are really looking forward to work with our Arab colleagues in the Pan-Arab Society to spreading this. This is one of the reasons why we created the Pan-Arab Society, is to encourage collaboration and research. I will give Philip, I will give you the last word. And before I leave, I want to thank Professor Bousquet for being with us today. I want to thank all the audience that was with us today, reminding you that this will be available on a recording for the next month. Thank you for Professor Carla. And Philip, I'll give you the last word.
Well, thank you very much. You know, it has been a great experience with that, you know, and the work never ends. We're very proud, you know, of the achievements of area and the mask air. You know, the OECD has really crowned all of that. The Organization for Economic Cooperation and Development has really recognized the mask air. Now, we always talk about, you know, poor management, poor control of the patient. This is the time to really do something about it. And as I said, the more we log in patients, the more data we're going to get, the better is going to be the management of our patient. So really, let's seize this opportunity. Everything is aligned, you know, for the benefit of the patient and also for the benefit of the physician. So please, I urge you, go ahead, you know, get acquainted with the system, and, you know, I would be available, and the Lebanese Society also would be available for any advice regarding this. I want to really thank you very much for for being here. You know, Carla and you know, Jean, you've been always supportive, and I congratulate you. I really don't know how you can find time to do a zillion things, but thank you again, and God bless you.
Thank you so much, and thank you for inviting me.
Thank you.
Thank you. Goodbye.
Bye.
Goodbye.